Good afternoon, everyone. This is Kevin McGinnis, bringing you the Community Paramedicine Insights Forum for September 2018 on behalf of the National Association of State EMS Officials, National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research. We are pleased to bring you a session this month on social work and community paramedicine, being presented by Malachi Winters, who is the program manager for the Sedgwick County Office of the Medical Director for the EMS system. He oversees their critical care, community paramedic, and links programs. And prior to this stop in life, he was the lead instructor for the paramedic program at Cowley County Community College. He's currently pursuing his bachelor's in social work from the Wichita State University. We're glad to have you back after our brief summer respite, and we're very pleased to bring you today's session, our first on social work in community paramedicine. Malachi, you want to take her away?
Yeah, thanks. So today we're going to be talking about integrating social work into community paramedicine programs, something that we've been trying out in our system, and I know that a few other people are trying it out around the country, and I want to, basically let everyone know about how it's working for us and kind of let you know about the other programs and systems around the country that are doing this as well. So as far as disclosures go, I have no conflicts of interest. One disclosure is that Ascension Health provides funding for one FTO for our community paramedic program. That's one of the local hospital groups. The parent company, Ascension, is paying for our community paramedic rather than the county. So we're located in Wichita, Kansas, which is smack dab right in the very center of the geographical lower 48. And population density for Kansas, if we're right here, this red spot that's down in the lower middle, that's Wichita, where we have a nice dense population, and surrounded all around us is that dark green means that there's 0 to 1 people living per square mile, and lighter green is 1 to 5. So you can see that most of Kansas is very sparsely populated, but Wichita is an urban center that's smack dab in the middle of the state. So between us and Kansas City in the upper right-hand corner, we account for most of the population of the state, but we still have to deal with a lot of the rural areas that surround us. So Wichita itself has a metro population of 644,000. We have a very large aircraft industry. A lot of the small jets and even medium-sized jets that are made in the country, parts of those, if not the entire thing, are made in Wichita. That's our prime manufacturing that we have. But just outside of town, if we go outside of the metro area, you'll find the wind industry is picking up, and we're getting a lot of, and the state provides a lot of wind energy. A lot of wheat is exported, a lot of cattle, so a lot of your steaks are coming from Kansas. And then I threw this last little picture up here on top because this is just outside of town in a little town called Towanda. You'll notice that crooked W. About 20 years ago, I was one of my first EMS calls when I was a brand new EMT. There was a 400-pound individual that was up painting the Towanda on this silo, and the winch and bucket that he was sitting in gave way, and he fell right where that W was. Unfortunately, he didn't survive. He had a transected trachea, but when his friends went back to finish the paint job, they made that crooked W as a tribute to him, and I still think of that every time I drive by there. So our service is Sedgwick County EMS, which covers Wichita and surrounding area. The county surrounding the city of Wichita has 61,613 emergency calls a year. We have 2 paramedic response, also have BLS, fire first response that occurs with every EMS 911 call as well. Like many metro EMS programs, we have a community paramedic program, and underneath that community paramedic blanket umbrella, we have 3 distinct programs that do have some overlap with each other. The first one is the high utilizer program, which is pretty similar to other high utilizer programs where we are really trying to identify and target individuals and reduce their unnecessary 911 usage. We also have a dedicated CHF readmission reduction program that is contracted with one of our local hospitals, and that's the one that pays for the community paramedic in order for us to keep their 30-day readmissions out of the hospital for congestive heart failure. And the last one is our LINKS program, and the LINKS program is a partnership that we have with local universities where we allow graduate level Masters of Social Work students come in and do a practicum with EMS and focus on seeing clientele from the pre-hospital perspective and get them linked up with some more appropriate resources in the community besides 911. You know, as just said before, social workers are an integral part of our community paramedic program. According to the World Health Organization, integrated social and medical services can be 10 times more effective than waiting for families to visit health services on their own and to seek out the health on their own. And, you know, to further illustrate this, this is a model that was put together by the County Health Rankings, and, you know, basically showing that clinical care really only accounts for about 20% of a patient's outcomes. Most of the things that really affect patients' health are health behaviors, social economic factors, and the actual physical environment that they're living in. And the clinical care that's provided by nursing, doctors, paramedics really only affects about 20% of their health. You have to address these other factors if you want to make meaningful change in someone's health status. And what we also found in our system is that, you know, while in other parts of the country, community paramedics are kind of filling that role of being a social worker, particularly in ultra-rural areas where there just aren't social workers available. That's not the case when we live in a metro urban city where we actually have quite a few social workers and quite a few resources that are available. It's just getting the clients connected up in the right manner to that. And so it's not a lack of the social workers. We don't want our community paramedics to really be social workers. They have more important things to do in our system, the way our model is built. And so we've integrated the social workers in there to help support them and help streamline the work that the community paramedics are doing. So some of the advantages that we've come up with this integration of social workers into the community paramedic program, there's a higher level of training and expertise for addressing social issues, as opposed to giving a couple of weeks of training to our community paramedics about how to do social work and then getting them out there and having them do that, which is still important because that still incorporates a large chunk of what they do. We found that it is very helpful to have somebody who has a master's degree in that type of advocacy and liaison work where they can quickly get someone referred off to the appropriate agencies. Social workers, all of ours are master's level students, or so everyone that's involved has had at least 6 years of education in this field. We found that there's a larger, more robust network of resources that we can connect people up to, and greater support of the community paramedics and nurse practitioners in our CHF program. When they run into an issue that a social worker needs to be addressing, it's very easy to just get that referred off to the social worker, and then the community paramedic can go back to dealing with direct medical issues. We've also found that it leads to a more immediate addressing of needs when those are identified, and frees up more time for the medical providers to practice medicine. So the first role that social workers are used in our program is to help out and augment the CHF readmission reduction program. This here is TJ, and he's seen one of his clients. TJ is our lead community paramedic, and he does a lot of work directly with the Via Christi Hospital system, which is Ascension is the overseeing company that owns Via Christi, and they pay for TJ's salary essentially, so he can keep people out of the hospital after 30 days after dismissal for CHF. Based on many other similar CHF programs around the country, the one difference is that TJ is part of a focused CHF team. So you'll see TJ here with a nurse practitioner and one of their clients, Michael here. Michael was actually at one point admitted for CHF 23 times in a 1 calendar year period. 11 of those times he was a STEMI alert. Obviously he was just absolutely draining the system. Once TJ got involved and we started really focusing in on him, we have actually reduced his call volume down to 1 911 call in the last 18 months. So it really made an impactful difference on that individual's life. Over here on the left, you'll actually see the whole CHF team. And of this team, there's a physician here in the middle, 2 nurse practitioners, 2 full-time social workers, and 2 RNs that are dedicated to the team. And so they run like a Group A and a Group B. And so when TJ is dealing with one of his CHF clients and he runs into a social issue that needs to be addressed, he can immediately kick that off to the social worker that's part of the team and have her start working on that issue. If he runs into a complex medical need that's beyond his scope, he can immediately kick that off to the nurse practitioner. We found that this is a very efficient model, and we made a lot of headway, and not just on the short term. When we're looking at our the patient's usage 12 months prior and 30 days prior to the 30 days while enrolled in the CHF program or the Community Paramedic program, and the 30 days post, 90 days post, and 180 days post, you're seeing that even past the initial 30-day time period where they're enrolled, we're having lasting effects on healthcare and change because we're addressing the patient as a whole and not just focusing on only keeping them out of the hospital for 30 days. We're trying to change health behaviors and get people connected up with resources that they don't normally have. And while the original goal was to keep them out of the hospital for 30 days, it's having a lasting effect that continues on further out. So while we have the dedicated social workers that are part of the Via Christi team, part of the CHF heart failure team, the question comes up of what do we do for those members of the public that we run into as that aren't part of the CHF program. So, and that's where it comes into our partnership that we have with the 2 local universities. Wichita State University and Newman University both have master's level social work programs. And we partner with both of those schools to get practicum students to come in and do a 1-year practicum with EMS. So that practicum usually starts in the fall, goes all the way through the spring of their senior year. They do between 16 to 20 hours a week of practicum time, and they're supervised by a social worker in the community who comes in and observes them once a week. These university programs will actually take referrals from anyone in the system, whether that be the fire department, the police department, EMS, 911 communications and dispatch. Anyone can refer any client to this program for any need that they see. It's pretty much a blanket statement of if you see a need that's not being met, send us a referral and we'll send a social worker out to address those and see what we can do to get those people hooked up. So here's our last social work practicum student from last year. This is Andrea and one of our other community paramedics, Brooke. Again, as I was saying, the practicum is a year long, which is about 800 hours total, and it's for master's level social work. So any first responder can do the referrals. Home visits is usually done in conjunction with the community paramedic and a social worker together. We found that having those two lenses are complementary, where the community paramedic is looking more at the medical aspect of things and is able to look at medicines and interpret things from that level. The social worker is looking at their own set of criteria that they're trying to assess, and putting those 2 viewpoints together really gives a very holistic, broad view of the client, and we're able to really address what the underlying needs are, which oftentimes are not what the client originally was referred for. So as far as the specific model of the type of social work that's being used, solution-focused brief therapy is the term for that, and really we're not trying to do the work to fix the client's ourselves. We don't have time for that. What we are trying to do is immediately solve problems that the client perceives that they need help with, and get them referred to existing agencies and existing resources that already are out there in the community. A lot of the problem that we found is that the solutions exist, the public just doesn't know how to get connected up with them. Which kind of brings us off to the to part 2 of this presentation. Part 1 being I told you guys about what we're doing in our system, but I think that it's of note that we're not the only ones that are incorporating social work into EMS. And I think that it's important to note that, you know, these good ideas are popping up simultaneously around the country. So far we've been able to identify 10 other programs from Spokane, Washington, to Las Vegas, Nevada, to Tucson and Mesa, Arizona, to Tuscaloosa, Alabama, Colorado Springs, Colorado, and Tulsa, Oklahoma, and Johnson County, which is Kansas City, Kansas. We've been trying to get these individuals together and do quarterly conference calls where we update each other about our different programs and the different structures that we're using and the different results that we're having, and to just kind of talk through the issues that we're running into, and that way when somebody makes a mistake, we don't all have to make that same mistake, and when somebody finds an easy win, we can all copy or benchmark off of that. So we found that there's a lot of different ways of doing this. While Sedgwick County is utilizing the hospital social workers for a specific disease process and is partnering up with universities, there are other ways to incorporate social work into EMS. Over here on the left, you'll see this is Colorado Springs in Colorado, and on the right is Tulsa, Oklahoma. Both of these are using community response teams where there is a mental health social worker that can do mental health clearances and can actually do mental health holds, and a police officer and a firefighter, RN, paramedic. Together, the three of them drive around and clear up mental health calls and make sure that police units and EMS units can go available, and they'll pretty much take care of it. It's kind of interesting. One of the things that they can do is they can do full mental health and physical screens. So if somebody does need an inpatient psych bed, they can go directly from the field, bypassing the ER because the paramedic does the full physical screen, and go straight directly from the field, being transported by this CRT team to a psychiatric bed, so we don't have to stop for medical clearance. Tulsa is using a very similar model. In fact, they work pretty closely with Colorado Springs to build their models based off of them, but they are running 2 days a week, and they're still in their initial phases, but they reported having very similar successes and really being able to free up initial units. Other services are also using the partnership with university to get Practicum students in model. Some of them have been doing it very well and very robustly for a while. Over here on the left is the CARES program operated out of Spokane, Washington. They've been doing this for about 10 years. And it has gotten to the point where so many social work students are going through that program. Right here you'll see that there's about 8 Practicum students they have for one semester. And they're so prevalent and so many students come through that many of the social workers that are out in the actual agencies in the community got their feet wet doing pre-hospital EMS work. And so when these kids are making referrals and calling in to other departments, usually what those people that are receiving the calls are very aware of this, and it's kind of evolved in their community as being this is the first line for accessing any services in the community is getting connected up by the CARES program up there. Over on the right, we have Tuscaloosa, Alabama, which is partnered up with University of Alabama, and they've been doing it for a couple of years, and Still haven't had any full-time funding. I'm kind of in that same boat myself where I'd love to have a full-time social worker, but just haven't been able to convince the electeds that we need to pay for that yet. Another example is the Southern Nevada CHIPS program, which is covering Las Vegas and surrounding area. This is a nonprofit agency that was originally started by one of their graduates out of UNLV. UNLV was Dr. Carlton Craig, who runs their social work program out of that university, had started sending out social work students to ride along on ambulances and to actually be part of the team for response, which was pretty beneficial for grief counseling and immediate finding of resources, particularly when big things happen. And I know they utilized that team when they had their had the unfortunate mass shooting, that they were doing immediate grief counseling and debriefing. Anyway, one of their graduates a couple years ago really identified the need that they definitely could reduce a lot of call volume of their high-frequency callers, but there's so many different agencies that are operating that they needed a central point that was separate from each individual agency. So she started a nonprofit agency and has 4 full-time social workers and at any given time 18 practicum students. So there's a large force multiplier there, and they serve all of Las Vegas and the surrounding area and contract out with the individual first response and transport agencies, both private and public. So next steps of things that I would like to do with this group is, as a whole, we've all kind of been talking to each other and lamenting the fact that the good work that is being done by using social workers and EMS, it's hard to translate that into dollars and cents because a lot of this work is so time intensive. In order to do it right, it doesn't come out on the other end looking as being of great value, and that's a hard thing that every one of us in this group has had trouble conveying to our stakeholders. And so we'd like to get together and maybe define some good KPIs that we can all use, the same similar language, and talk about how we're tracking our calls using the same language as well. So that's a project that I'm wanting to get started sometime soon, but I anticipate it'll probably be a good 18-month long project to get that moving. But we would also like to expand our network of agencies. Something tells me that the 10 services that I've identified so far that are using social workers and EMS is not a complete list. And so we're trying to reach out and identify others and have them come and join in on this group as well. And I'm going to leave my contact information up there, and I guess I'll use this as an opportunity to open up if you guys have questions.
Thanks, Malachi. This is Kevin. Great presentation. Very enlightening. I will give Gary just a second to unmute all of our callers. With a question, I know that one of the programs we featured many years ago was Wake County, which does not use social workers per se, but has a behavioral response component to their advanced paramedic program, and is based on strong relationships with faith-based behavioral health services in Wake County. And so the handoff is basically done after the paramedic does a medical clearance, and then they're able, through their strong relationship, to simply direct the patient to one of those faith-based services. To what degree is that handoff part of your program, the programs you're familiar with, a problem, something that has to be continually reinforced, or is it something that it was fairly easy in your setting to do from the scene of the issue to actually getting a person referred into a resource they weren't familiar with?
So what I would say, the experience that we've had is when a new practicum student comes in, we usually have to spend about a month to a month and a half of doing onboarding, where they get to go out and ride along on the ambulances, get to know the system and the culture of that, but then also building up and being introduced to the network of resources that we have. And we have people that over time, over the last 3 years, that we've slowly built up. I know who I need to call for Adult Protective Services in order to get an answer done, and get something done quickly. I also know the Department of Aging, that person. But getting the social worker connected up with those individuals and making sure that those face-to-face meetings happen. And really, it's all about building a network of people you know in the community. Once that's done, the handoff portion seems to be pretty easy for us.
The conference has been unmuted.
All right, so we have everybody should be able to speak up with a question. If you've got one, please go ahead if you have a question for Malachi. Okay, well, let me ask one more question. Well, perhaps others are composing them. Do you have community health workers in Kansas? And if so, do you contemplate integrating them in any way in your program, or does the team that you've built now do the trick for you?
I would love to incorporate community health workers in our program. Our model and our system, there still is some barriers and silos between behavioral health and the medicine side that we're working on diligently trying to get those barriers broken down. We're having some success, but we're not quite there yet. That definitely is a goal I'd like to move towards. Obviously, as I was talking about what other people are doing, some other people have been able to move a lot further than that. So the Tulsa, Oklahoma, the Colorado Springs model, they've had a lot of success with that. But also up in the Johnson County EMS system model, which is up in Kansas City, Kansas, the EMS Office of the Medical Director, Dr. Jacobson's office, does employ a community health social worker who can go out and do medical clearances, and she is operating independently. She has her own vehicle, but she can go out and do screens and holds and clearances, and she augments the system that way. So pretty much if they run into if the police or EMS run into a situation, they get on the phone and call for Celia, and she'll come out and do that. And that's been going on for several years, and they've had pretty good luck with that.
In the Tuscaloosa program, you said that they were looking to better fund their system so they had more full-time social workers, as you also indicated you are. What are the shortcomings there? Is it just simply the hours of availability of social workers to the program, or what?
So for me, and I hate to speak too much to Tuscaloosa for them or to put words in their mouth, but I feel like that we have similar issues. For me, one of the big issues of not having a full-time social worker with us is gap coverage. Once I get a new practicum student onboarded and into the system and they are going, everything goes great all the way up until the point that they graduate. And then I suddenly have this cutoff of services right as summer is hitting, and it's going to be that way until mid-September when the next year's student gets onboarded. And I know that's been something that Tuscaloosa has dealt with as well. Christmas break is another bad time when there's a lot of people that need help, but we just don't have the ability to offer that without having somebody that's full-time in our employ. It would also be very beneficial if we did have that full-time social worker that they could, on top of providing the gap coverage, they could take multiple students underneath them and provide direct supervision and guidance and really kind of grow the program and be a force multiplier for the program, which is kind of how the model of Las Vegas, their CHIPS program has worked, where you basically have 4 social workers and 18 underlings. So you can grow a pretty big program for not that many FTEs using that model.
Sounds great. Anybody in the audience have a question for Malachi? You must have told us everything we need to know. you have any parting comments you'd like to impart? Well, if not, Malachi, thank you very much for being with us today. That was very enlightening. For those of you out there, as I'm sure you know, this session and all of our previous sessions over the past 5-6 years may be found where you registered at cpif.communityparamedic.org. And we will let you know just as soon as this one posted. Our next program will be in October, on October 15th, Monday at 3 p.m. Eastern Time as well. And so thanking my partner in crime, Gary Wingrove and Mayo, for their support of this program and his technology wizardry in getting this program up every month. And on behalf of the National Association of State EMS Officials, the National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research, I want to thank you all for joining us this month. See you next month.